So, dear ladies and gentlemen, may I have the first slide, please? Yeah, that's right. So, thank you for the kind invitation. It's a great honor for me to be here in Greece and talking about the current management of diabetic foot. Here are my conflicts of interest. The estimated prevalence of diabetes was estimated about 9.3% in 2019, and it's going to be increasing in the next couple of years. It's estimated to be about 10% in 2030 and about 11% in 2045. So it's a big issue dealing in the next couple of years. Diabetes seems also to be among the leading causes of death globally. It was at the 9th place, according to WHO, at 2019, and also at upper middle income countries, it was in the 6th place. How about the costs? That's the diagram from 2013 in US. So the complications of diabetic foot ulcers, like limb complications, were estimated to have costed $17 billion. And it's estimated to $1 million is spent every 30 seconds on diabetic foot complications. The medical costs for people with diabetes are more than twice as high in comparison with people without diabetes. So let's talk about the diabetic ulcers. The lifetime risk for developing one in diabetic patients is estimated to be 34%. Almost 50% of them will become infected, and 20% of these infected ulcers will lead to major amputation. About 50% of heel ulcers will also lead to a major amputation, like at that case with a below-the-knee amputation. That was also very interesting to see that every 7 seconds someone dies from diabetes, and every 20 seconds, someone is amputated. What's the next after an amputation? 30% will lose the other leg within 3 years, and almost 50% of them will die within 5 years. And how about the real-world data? That was a very interesting paper published in 2013 from a cardiologist in Germany, and they make a comparison about the discrepancies between trials and real life regarding the acute myocardial infarction, but they also reported that about 40% of diabetic patients have been amputated without prior revascularization. For the management of diabetic foot ulcers, the Wunderbar is essential. The mechanical offloading with a couple of devices which are meantime available, the treatment of infection with antibiotics, the strength glycemic control, and of course, the revascularization. And I'm going to talk about that. We do have the well-established bypass surgery, preferable with vein grafts like the great saphenous vein. We have the endovascular treatment, and I'm going to talk a little more about that. And also the hybrid approach, which can combine the previous two ones. So we are vascular surgeons and simultaneously also endovascular surgeons in the same room. Up to now, we did have drug-coated technologies like drug-coated balloons or drug-eluting stents, which was the main treatment until the past years, either with paclitaxel or with sirolimus. But nowadays, we do also have some more sophisticated devices like the Atherectomy Device. And there are plenty of them. At that specific case, we do have an Oct Guided Athorectomy Device in which the catheter is introduced into the vessel lumen. And then with the help of this balloon, you can cut the atherosclerotic plaque precisely, because you do have simultaneously at the right side and the screen where you can appreciate where is your plaque in order to have an accurate cut only for the median. We do have Many more devices like this one, this is the intravascular lithotripsy. It's well known in the medical community by the urologists for the kidney stones, but during the last 4 years, we do have it also for the peripheral artery disease. Sorry about that. So in that case, a balloon catheter is introduced into the vessel, which is highly calcified. And with these shock waves, with it shock pulses, let's say, we do achieve a plaque modification of the atherosclerotic plaque with a calcium in order to achieve a better gain lumen. It's a pretty new device. Like Professor Donas before said, we do have also the option to control our results in the real time in order to achieve better results, like understanding the plaque morphology or even the diameter of our lumen. So that's the intravascular ultrasound. In that case, we're able to measure the vessel size. We're able to understand the plaque morphology, and therefore we're able then to apply the best medical treatment for our patients. When combining these endovascular tools, which are pretty new in this area, with advanced endovascular techniques, then we can achieve the best results. For example, retrograde puncture of the tibial vessels. I remind you the anatomy. We have the tibioperoneal trunk over there. We have the orifice of the anterior tibial artery. We have the peroneal artery and the posterior tibial artery. And then we could have a puncture of these vessels, either with ultrasound or through an angiographic run. That's the puncture of the dorsal pedal artery, in order to have the maximum effect. So that's some typical examples. We do have an occlusion, a lung occlusion below the knee, with almost none vessel below the knee. And after the treatment, we did achieve to have 2 vessel runoff up to the foot. Or even in that case, with only 1 occluded artery below the knee, and a retrograde puncture of the anterior tibial artery, we did have then antegrade flow up to the foot. But how about the so-called no-option patients? These are the patients, that's a typical example of someone of that. We do have only collaterals at the level of the foot, but no direct flow to the foot, because the anterior tibial artery is occluded at the level of the heel. So like some years ago, there was no option for that kind of patient. You should be amputated. But in the meantime, we can also make a procedure, a high complex procedure like that, in which we do achieve a deep vein arterialization. What's that? At that case, we do make a puncture of the plantar vein of the foot, and we insert a venous catheter from the vein to the leg above, and then with an arterial catheter, we have a crossing, like we place our catheters opposite to each other. Then we are able to make a crossing with a needle from the arterial side to the venous side. And then with the use of sophisticated valvulotome, we're able to destroy, to damage the valves of the vein. Then we go further with a deployment of a self-expandable covered stent, which is tapered in order to be able to be adjustable to the diameter of the artery and vein. And at the end, we do manage to have a direct flow to the foot, although in the beginning there was no flow actually. So that's an example of one case of that. And we do have, through the deep vein system, arterial flow to the foot. In order to summarize, the prevalence of diabetes is increasing, the costs are very high, a multidisciplinary approach is mandatory with many different medical specialties, The patient's referral is also very crucial. There are many treatment options, open surgery, many endovascular options also, and of course, highly expertise centers are needed. And remember, save a limb means save a life. Thank you.